Good morning, everyone. My name is Lynette Corona. I'm a healthcare program specialist at CDPH's HAI program. I was for today's webinar. Today's webinar is entitled Implementing Current Breakpoints for Carbapenems and Enterobacteriaceae on Your AST System, Step-by-Step Instructions. Earlier today, we sent several tools for participants to print out and reference during the webinar. If you did not receive these tools, please email Sam Horrocks-Schofield at the address listed on the introductory slide. To facilitate the session, we will request that all participants, when signing into WebEx, use the option to have WebEx call your phone by entering in your phone number. Doing so will allow us to unmute your phone during the discussion portion of the presentation. If you ask a question of the panelists or make a comment, please use your chat feature to message me, the host, and I will know to unmute your line to allow you to speak. You can also type in your questions by using the chat or Q&A panels. You can access these panels by hovering your mouse over the bottom center of the screen, where several icons will appear, and then click on either the chat or Q&A icons to open the panels on your screen. I will now turn the presentation over to Dr.
Thank you, Lynette. Good morning. Welcome everyone to today's webinar on implementing current breakpoints for carbapenems and Enterobacteriaceae on your antimicrobial susceptibility testing, or AST system. We're very pleased you've all taken time to join us today and to learn more about the following important learning objectives, which are to be able to perform the steps necessary to verify current breakpoints for carbapenems and Enterobacteriaceae on your laboratory's AST system, to discuss ways to overcome any barriers to implementation of current breakpoints, and then to describe mechanisms to ensure that your AST system is performing reliably following implementation of the current breakpoints. Before on, we'd just like to mention that the information and tools and references that are presented for this program reflect the opinion of the presenters and aren't formal recommendations or requirements of the California Department of Public Health or the LA County Department of Public Health. So presenters are going to discuss in detail the importance of using the most updated interpretive criteria that were first proposed in 2010 to identify carbapenem resistance in Enterobacteriaceae, and then step-by-step guidance on how you and your clinical laboratory can implement these current breakpoints. Now, you know, in public health, how do we know that this is an issue for California clinical laboratories? Well, the CDC's National Healthcare Safety Network, or NHSN, surveys hospitals each year about various infection control and laboratory practices in place in the clinical laboratories that serve them. And then we in the CDPH HAI program receive and analyze these annual survey data to identify our priorities for outreach. And this chart shows the proportion of these laboratories that reported implementing updated breakpoints since 2014. The purple trend line shows some incremental progress. Each year, a higher proportion of acute care hospitals are working with laboratories that have adopted updated breakpoints. But you can see in 2017, there are still 49 hospitals that are working with laboratories that reported using old breakpoints. Locally, we invited Janet Hindler to present on this topic and provide these laboratories the step-by-step guidance they need to implement current breakpoints. Janet has a wealth of experience as a clinical microbiologist for more than 35 years. She worked, written, and taught extensively in the area of antimicrobial susceptibility testing and has presented hundreds of talks and workshops to clinical microbiologists and other healthcare practitioners in 15 countries. She's with the CDC. She served as a consultant to the World Health Organization and the Association of Public Health Laboratories. She's a fellow in the American Academy of Microbiology and an active member of the American Society for Microbiology at both national and local levels. She received her education at Albright College, Duke University, and the University of California at San Francisco, and we're so pleased to have Janet join us. And then also, after Janet's presentation, we're also going to hear from Dr. Tam Van, who's the Director of Clinical Microbiology at Harbor UCLA Medical Center. And Tam is going to just go over her lab's recent experience updating their breakpoints, and she'll describe some of the challenges they encountered and how they overcame them. So I'd like to turn over the presentation to Janet Hindler. Okay, so Jay, I've passed control of the WebEx to you.
Thank you, Erin, and thanks to all of you who are tuning in with us today. Now, I know this isn't the most exciting topic in clinical microbiology these days. We really appreciate your interest in learning more about what you can do to make sure you're doing the right thing with antimicrobial susceptibility testing for your patients and for the public health. Now, I mentioned that we all know there are many challenges in susceptibility testing these days. This session is going to be very focused on making sure very soon all of us will be using the current breakpoints for carbapenems when testing Enterobacteriaceae. So, get the slide, please.
Hi, can you go ahead and make Erin the presenter again? Or Lynette can change them as well. Sorry about that.
Oh,
and can you use slide 1, Lynette?
We were all done, but we're not there yet. There we go. Thanks so much. Okay.
Lynette, you can transfer.
Back to Janet.
Thank you.
Okay, got it. Okay. So as Erin mentioned, that we have provided quite a few resources for you. We want to make this process as painless as possible. And so you should have gotten all of these with the exception of the slides in an email this morning. Now, we will subsequently make the slides available to you as well. Among the packet of information, we have a checklist, and that describes step-by-step what you need to do to implement the current breakpoints. We all have a protocol you could use for your verification documentation. We have worksheets where you can record your results, and also have the listing of susceptibility results for the isolates that we're going to be suggesting you test in the verification. We're going to talk a lot more about these. And so a picture of all of those is on the bottom of the slide right here. And I suggest, at some point that you look at these thoroughly because these will help you with your verification. So why is this so important? Recently, or actually a couple of years ago, CDC labeled CRE as an urgent threat to public health. Now, all of these points that I'm going to give you in the next few moments are in Appendix B in your checklist, because we included this because you may need some support information to take to your laboratory director to support you in giving you the resources to do this verification. And there are some significant recent references in that listing as well. So you don't need to look at it now, but go to Appendix B at some point. You have to convince your administrators that this is something essential to do. So CRE is a significant public health and clinical threat. Okay, also know that there's a lot of CRE in Los Angeles County and in the state of California. And some recent data now analyzing the susceptibility results from isolates in LA County demonstrated that if you're not using the updated breakpoint, we can be seeing as many as 20% of CRE. And two, this is substantial documentation saying this is the thing that we need to do. Okay, outdated breakpoints obviously can direct treating physicians to using the inappropriate drugs, and this could lead to significant patient morbidity and mortality. And the outdated breakpoints can also hinder the recognition of CRE, so this can have a significant impact on appropriate infection control and epidemiological investigations and methods to curtail the spread of CRE. Okay, this slide demonstrating that this is very significant, again, overall in the United States. Some data from 300 hospitals in the U.S. showing that hospitalizations due to CRE is increasing. To now emphasize that CRE is not just occurring in tertiary care centers. We're seeing CRE in acute care hospitals and long-term care facilities. And what this means is that any of us working in any clinical microbiology laboratory in the United States have to know about the optimal methods to detect CRE and identify CRE in their laboratories. So no exempt from this. Now, some data in California and in Los Angeles County. Okay, so back in 2015, the CARLA survey was did by the state, and CARLA was the California Antimicrobial Resistance Laboratory Network Assessment. And there were questions that were answered here, and this was a project, again, by the California and Los Angeles County Health Departments. The bottom line of this was we wanted to find out what clinical laboratories were doing in terms of susceptibility testing. And, one of the goals was to see, how many laboratories are using the current breakpoints for identifying carbapenem-resistant Enterobacteriaceae. The result of that survey showed that 28% of laboratories use outdated breakpoints for carbapenems in the Enterobacteriaceae, and those that use the outdated breakpoints, many of them did not perform carbapenemase testing that is recommended by CLSI if you are not using the current breakpoints. Okay, so, and as a result of these findings, Los Angeles County took some measures to look further into how they could help clinical laboratories in Los Angeles County to update to the current breakpoint. And so from the CARLA survey, there were 41 laboratories identified that were using the outdated breakpoints. And as they looked at what was happening at that point, 7 had then updated the breakpoints, which was wonderful, but 34 laboratories that were still using the outdated breakpoints. Now, 27 thought they were using the updated breakpoints. So this reflects a breakdown in communication that many laboratories don't even know how to find what the current breakpoints are. 17 did not know how to update the breakpoints, and 10 didn't have the staffing or other resource to update the breakpoints. And I extend a thank you to Dr. Jamie McKinnell in particular and his team who went out to these hospitals not only to look at what's happening in the laboratory, but also to encourage others in the infection control and hospital administrators to emphasize that this is a significant problem and laboratory support is essential in addressing this problem. Okay, after a follow-up visit to these 34 laboratories, and the laboratories were given some information to assist them with the breakpoint updates and protocols and so forth. 16 did update the breakpoints, 12 procured isolates to perform the update, and 6 planning to obtain the isolate. So there was significant outcome from these visits to these laboratories to get to update the breakpoints. A little bit of background information about breakpoints and what we know about these breakpoints. And in the survey, some laboratories didn't know what the current breakpoints were. So where can you find information about the current breakpoints? And the best place to do this is the CLSI document, the M100, which most of us in clinical laboratories use on a frequent basis. And we know these M100 tables are updated every year. In January, the most recent version is the M100 28th edition, and have taken a snapshot of the table that has the breakpoint for carbapenems and the Enterobacteriaceae. And this is table 2A. So the top talks about the testing conditions for the reference methods, and at the bottom you will see the current breakpoints for the carbapenems, being doripenem, ertapenem, imipenem, and meropenem, and this is where you can find the most updated breakpoints. Okay, if you don't have the current M100 document, there is some solution. You can go to the CLSI website and obtain a read-only version for free. So what you do is you go to clsi.org, you click on the resource button on the first page. That takes you to a second page where you have another button that you click on, which is free resources. That takes you to a third page where you actually click on the button for access to the M100 document. Now, as mentioned, this is for on-screen use only, so you can't print from it, but you can definitely look to see all the information that's in the M100 document, and it's not that difficult to access. Okay, and these are the current breakpoints for the carbapenems and Enterobacteriaceae on the right, and on the left are the old ones. So one of the first things you're going to have to do is to see what breakpoint your instrument is actually using, and you could use this chart to help you with that decision. Okay, breakpoint reminders. Okay, in the United States, both the CLSI and the FDA set breakpoints. The carbapenem breakpoints for Enterobacteriaceae were updated by CLSI 8 years ago, and a little bit more recently by the FDA. But now we can say is both the CLSI and the FDA breakpoints are identical. By law, manufacturers of commercial diagnostic susceptibility testing devices have to use the FDA breakpoints, so those now are the same as the CLSI breakpoints. The problem is not all commercial susceptibility testing systems are updated with all of the current CLSI and FDA breakpoints. Now, we would all like them to do this. There is no regulatory mandate for the manufacturers to include the current breakpoints. And unfortunately, for some of the manufacturers, this is not a priority for them. So it should be easier for us. We should not have to go through this verification procedure. You know, we would hope that the manufacturers would all update these breakpoints. They made significant progress, but they're not all there yet. The thing we need to know is that clinical laboratories must perform a verification for an AST system, commercial AST system, if you're using breakpoints other than those that are FDA cleared on that system. So if the old breakpoints are what's FDA cleared on the system, in order for you to adopt to the current breakpoints, you're going to have to do a verification study. Now, in your handouts, we provided a list of which breakpoints are outdated on respective systems, and I'll show you that in a few moments. But it's for you to check with the manufacturer of your system to find out the breakpoint status, because as I mentioned, progress is being made, and this change any day. Now, it's one thing to have the FDA breakpoints cleared by the FDA. It's another thing to have those updated breakpoints actually implemented in the software, so you actually be applying those breakpoints in your system. So that's other information you need to find out from your manufacturer. Okay, now, what do we know about verification? According to CLIA, and we all know what the CLIA regulations are, we have to verify our tests. There is this statement in the CLIA regulations: the user must demonstrate performance specifications when using a test that is not FDA cleared or using modification of an FDA cleared test before use for patient testing. We have to analyze accuracy and precision. We have to make sure the system is performing accurately and reproducibly in order to comply with the CLIA regulations. Other criteria that CLIA specified in these regulations, and there's on the bottom of the slide here, you can see what regulation that actually is. These three at the bottom, the reportable range and so forth, are pertinent to susceptibility testing tests. Okay, what we can say is that applying the current carbapenem breakpoints to Enterobacteriaceae in a susceptibility testing system is modification of an FDA-cleared test if that system does not have the current breakpoints in its software. And these are the situations where we're going to have to do this verification. And again, too, I've listed the old and the current breakpoints on the bottom of this slide. Okay, something we know about the CLIA rules is that they're very general. They don't highlight, how many organisms we have to test, or what comparative method we have to use, or what are the criteria for susceptibility. So these decisions have to be made by the laboratory director. So there's a lot of flexibility here. So basically, when you're deciding exactly what you're going to do, we're going to give you some guidance, but you can make some alterations to this guidance we're given, and it's based on your laboratory director's input. And this information is actually found in this CLIA surveyor guidelines, which is, the link is listed on the slide right here. Okay, I want to emphasize is that there's a difference between verification and routine quality control. Now, for many years, most laboratories thought that when you have a new susceptibility testing system in your laboratory, all you need to do to get it started is do 20 days quality control or 5 days of quality control in triplicate. But that's not true. You also have to do this verification. And verification, we're going to do that before reporting patient results. We want to ensure the results from the new system or the modified system are reliable. They're both accurate and reproducible. And as we do quality control, after we do the verification, and we're going to do it concurrent with the verification during the verification process, but then we're going to continue to do ongoing quality control to make sure the system is performing reliably. Now, I'm not going to talk much about, how frequently you need to do quality control. But recently, when the IQCP, the Individual Quality Control Plan Initiative, came into effect, we have to have documentation in our IQCP if we want to convert from daily to weekly quality control, because the regulations specify that we have to do daily quality control for susceptibility tests unless we prepare an IQCP that says it's not essential to do that in our facility, because we have supportive information that weekly quality control would be satisfactory to monitor accurate and reproducible results. So we're going to find some information about verification of susceptibility test systems, specifically commercial systems. And in 2015, the CLSI came out with a new document, Verification of Commercial Identification and Susceptibility Testing Systems. Now, in that document, we talk about verification of a new system. So if you were using a Phoenix, you bring a Bitech in your laboratory, you have to do a verification, which is qualified as a full verification. However, you also need to do a verification if you make some alterations to your susceptibility testing system, such as if you add a new drug. And so updating breakpoints. And these are considered limited verification. So the verification does not need to be as extensive as full verification you would have to do when you bring on a new system in your laboratory. And very specific instructions for this in the M52 document on page 51 of Appendix B, if you want more information about that, although we're going to cover it in this webinar. Okay, basically just to lay it out so we can kind of understand where we're going here. For verification, we have to test each isolate by the reference method or obtain a reference result, and by the new or the modified CAST system. Okay, we're talking about breakpoints. It's a modified system, so we're going to have to test the organisms, considering those new breakpoints, look at results, compare to the results using the current breakpoints with the reference method, and then determine whether or not the new system or the modified system is performing reliably. The other thing I want to emphasize, we have to maintain this documentation in our laboratory because during our inspections by CLIA or CAP or whatever, they may ask us to show them the documentation that we have formed these verifications, and that's not unique to susceptibility testing. You know that all of us, the tests, we have to do this as well. So we get the reference results for used in a susceptibility testing system verification. And we can also call these reference results or comparator results. And basically 3 ways we can get those results. One would be to test those isolates in our laboratory with a commercial system and also with a CLSI standard reference method, and those being Broth microdilution or augdilution, semi-seeds, or disk diffusion. Those are the CLSI standard reference methods. Or we also test isolates and compare the results of our modified test with the method, another comparator method that's an FDA-cleared susceptibility testing method that was previously verified. So let's say you have a Phoenix in your laboratory, and that was verified for the current breakpoints. We want to modify the breakpoints on our Vitek. We can compare those results on the Vitek to those from the Phoenix because those were previously verified. Or obtain isolates with no susceptibility results that were verified from a verified system from an outside source. And that's what we're suggesting that you do when updating your current breakpoints for carbapenems and the Enterobacteriaceae, because we're going to suggest you use this reference set of organisms from the CDC and FDA antibiotic resistance bank. We're going to talk a little bit more about that. And that's the easiest way to go because you only need to test these isolates on your commercial systems. You're not going to have to test them in any other comparative method. We have to look at during this verification, according to CLIA, we have to look at accuracy. And for susceptibility testing, we look at categoric agreement, which is SI and R agreement. If looking at cefepime, where there's no R, where there's an SDD, susceptible dose-dependent criterion for interpretation, we consider that the same way as we would consider intermediate. If looking at comparing MIC results, we look at essential agreement when applicable accuracy. For reproducibility, we look at reproducible results from the SI and R interpretations by the newer method or the revised method compared to the reference method. And we look at MIC value reproducibility when accepted variation plus or minus 1 doubling dilution for bacteria or plus or minus 2 doubling dilutions for yeast. So this is very specifically spelled out in the M52 document. Also look at comparing interpretive results and MIC results. And we could describe categoric agreement, and this is when the SI and R results agree. We want categoric agreement to be at a level of at least 90%. Essential agreement, we look at comparison of the MICs within plus or minus 1 doubling dilution of the reference result. Again, want to see at least 90% agreement among all the isolates that are tested. Okay, also categorize the various types of errors into major, or minor errors. And a major error would be a false susceptible result with the commercial system as compared to the reference or comparator result. Error would be a false resistant result as compared to the reference result. The acceptable error rate defined overall in the M52 document is less than or equal to 1.5% for major errors, less than or equal to 3% for major errors. We'll talk a little bit more about the criteria that are specifically for when you're updating the points, which is a little bit lighter than this. For minor errors, that means one system is going to generate an SR result, the other system an I result. And so reference can be the SRR result, and the test system, the commercial system, an I result, or else the reference can be an I result and the test or new system an SRR result. So the acceptable error rate for minor errors is really not specified. Again, this is at the discretion of the laboratory director. Calculate the essential agreement and categoric agreement. Now, for the purposes of updating the breakpoints, we really only need to look at categoric agreement, and I'll mention that more in a moment. And this is when you have the same, to calculate categoric agreement, we have the same SI and R results with the new system or the commercial system as compared to the reference MIC over the total number of isolates tested and times 100 to get that percentage. Essential agreement was looking at MIC comparative results. We look at the number of isolates within plus or minus 1 2-fold dilution of the reference or comparator MIC over the total number of isolates tested. And for calculating very major errors, now you can only get a very major error when you're looking at resistant isolates. Very major error is a false resistant result. Okay, this is with very major errors over the total number of resistant isolates times 100, and for major errors, it's the total number of major errors over susceptible isolates times 100. I looked at this slide a billion times, and I think I have this backwards. The major errors would be a false resistant result. Very major error would be a false susceptible result. I apologize for that. I will correct it when we distribute the slides to all of you. But anyway, times 100. So the very major errors are false susceptible results. The major errors are false resistant results. The minor errors is when one system's I and the others are S. To be over the total number of isolates tested. I apologize for this because I know this is very confusing and I'm making it even more confusing. Okay, examine reproducibility of a commercial susceptibility testing system. Okay, so we test isolates we could select a few isolates for doing these reproducibility studies, and they could either be the ATCC quality control strains, or we could select some clinical isolates, or we can select some isolates from the reference set of organisms we're going to be testing in this variation. And we would like to use isolates that have on-scale endpoints available. And we mean by an on-scale endpoint that the MIC value is not less than or equal to or greater than the highest concentration tested or the lowest concentration tested. And according to the M52, what we do is we test each of these organisms 3 times using 3 separate inocula, and we test over 1 to 3 days on the commercial test system. So we only do reproducibility studies on the new method or the modified method. We do not do reproducibility studies on the reference, using the reference method. And again, too, this is a little bit different than some laboratories have done in the past where they've tested, organisms, 10 times or 15 times, but in the M52, this is what's recommended. Some doctors do not agree with this, and they feel you need to do, 20 repetitive results to look at reproducibility. But again, too, I think in making that decision, you look at what's in the M52, discuss it with your laboratory director and decide what would be a plan for your facility. The acceptable results from reproducibility, 95% of the MIC results have to be within 1 2-fold dilution per essential agreement. I also say if you're using the quality control strains, 95% must be within plus or minus 1 dilution and within acceptable quality control ranges. In terms of the reproducibility of SI and R results, there's no number specified in what would be acceptable in the M52. Again, this is up to the discretion of the director, but we're going to give you some advice here. So what we're going to do for reproducibility for the breakpoint panel, basically up to the laboratory director, but suggestions would be, if you're just updating the breakpoints, ideally, you would previously have done a verification study on your system. And during that time, you've done reproducibility studies. Now, in reality, many of our systems that we're using in laboratories were implemented many, many years ago, and the records for the verification study may not exist. So you'd want to do at least a minimal reproducibility study just to comply with the CLIA regulations for the verification aspects. Okay, so what I want to do here, if you do have records of reproducibility previously, you can look to see what those reproducibility studies involved, and did they cover the current breakpoints that are going to be applied? No, there's really a need to do further reproducibility studies, and I know in many laboratories they felt that was not needed. But again, too, if you have no documentation of this, you might want to do at least some limited, minimal reproducibility study. So can you do this? You can test some of the QC, you know, ATCC 27853 is good because it has on-scale endpoints, or select an isolate from the Enterobacteriaceae breakpoint panel, which we're going to suggest you use for the verification. And I just said number 3 looks like it would be a good one. And 2 or 3 isolates tested, you know, 3 times over 1 to 3 days would be sufficient in my mind for reproducibility documentation. Okay, so let's get into the carbapenem-Enterobacteriaceae verification study. Okay, so this is one of the documents that we provided for you, and it includes step-by-step instructions with resources to support various steps. You know, have resources and comments up there. And so some of these, you know, are pretty simple. Others of these, you know, will require a little bit of thought. But hopefully, by going through this, you will have a better idea of what you need to do this verification. And again, there's some additional appendices with additional information. Like I mentioned previously, Appendix B has a listing of why you need to do this, you know, with references that you can give to your administrator. There's also a little appendix in here about what supplies you need to do this verification, you know, supplies you need to consider for doing this, and so forth. Again, to try to make it as user-friendly as possible to help you think about all the aspects you're going to need to consider when doing this verification. And this is specifically for updating the carbapenem breakpoints for Enterobacteriaceae. So we provided a verification protocol. So, you know, as part of this process, you're going to have to write a protocol explaining what you've done for this verification. And we provided this one for you, but you cannot just lift this and put it in your verification study packet because you have to customize it to your laboratory. Because here we talk about commercial susceptibility testing system XYZ. So what I'm going to do there is fill in the actual system name that you're using. You know, you're going to be verifying probably all drugs because we have all 4 listed here. You know, we also have some suggestions that you include when your system was initially verified, when you brought it into your laboratory, originally verified, but you may not have that information, so you could probably delete that sentence. It's probably not going to matter that much. The concentrations on your drug panel and so forth. The other one to emphasize is that you're always supposed to write the verification protocol before verification begins to include what you consider acceptable performance criteria from that verification. So this is a general rule for verification study or any verification study you might do, and then get the director's approval. Okay, talked about the isolates you're going to use for the verification, and we're suggesting you procure those from the CDC and FDA antibiotic resistance isolate bank. And you can find access to this by Googling AR isolate bank. And it's pretty intuitive about how you go about ordering organisms from this AR bank collection. And the specific panel we're going to order is the Enterobacteriaceae carbapenem breakpoint panel. Again, this is specifically for this purpose, but actually it has another side purpose, which I will mention in a moment as well. What is the CDC and FDA AR bank? It's basically this repository of organisms with a variety of resistance mechanisms and MIC values. And it is for these to be used by industry, researchers, laboratories, and others, you know, in developing new tests, in developing new drugs, to target new drugs on some of them more resistant organisms, because there's a lot of resistant organisms in this collection, and to validate current tests. And basically, there's a number of sets, panels of organisms, and this is a representative example here, the Enterobacteriaceae carbapenem breakpoint panel, which is going to be the one we're going to order. Dr. Tam's going to talk about, Dr. Van's going to talk about using the gram-negative carbapenemase detection panel, the ceftazidime AB-Bactam panel, and so forth. But before these, you have to understand, you know, how they're going to be used in your laboratory, because you know, lots of organisms in this panel, and you could be inundated if you order them all, because they come frozen. You're going to have to store them in the freezer, and there are some logistical considerations when deciding, you know, what panels to order. And these panels are accompanied with MIC and SINR result values, and also in many cases the molecular characterizations of these isolates. And so any isolates from the CDC and the ERA bank, if you do this, you register, and your registration must be approved before you go ahead and order, because they're not going to send these organisms to anybody. You have to be working in a clinical laboratory or other research facility where it's legitimate for you to get these organisms. You order, and then there's some other forms you need to complete. And actually, at the end of this presentation that we're not going to go through, I've included some screenshots of the actual steps to go through for doing this. Like I said, it's pretty intuitive. If you have a problem, navigating this, please, what I would do, and then you ask the youngest person in your laboratory to help with this, but I don't think you're going to have difficulty. You are going to have to complete a materials transfer agreement and also biosafety compliance form that is signed by your biosafety officer or your laboratory director, because again, too, CDC wants to make sure that these organisms are going to the right people and not just anyone like from the public who's just interested in having these in their refrigerator. I get these. They take about 1 to 2 weeks to arrive, and they arrive frozen. Okay, mechanism for storing these. Okay, over the study in brief, and again, too, this is outlined in detail in the protocol, and a lot of information about that is in the checklist as well. So in this Enterobacteriaceae carbapenem breakpoint panel, there are 31 isolates. You see 31 isolates just on your commercial susceptibility testing system. You're reading the results on the log sheet we provided, and you're not going to record the SI and R. You're just going to record the MIC results. You're going to interpret each MIC result at SI, SCD, or R with the current CLSI breakpoints. You're not going to look at the interpretations that were provided by your instrument. Then you compare these SIR results with the CDC reference result for each isolate. Okay, now, just have a little comment on the bottom of this slide. There's really no need to compare MICs because we're not really changing with the way we generate or look at MIC values. Manufacturers of these systems already have FDA approval for performance of MICs on their systems, so it's not essential to look further at the MIC values. Calculate categoric agreement, very major errors, and when doing this type of verification to update breakpoints, the M52 specifies no major error, very major errors are allowed. For major error, only one is acceptable. For minor errors, it's up to the laboratory director. But obviously, if you're going to have more than 10% minor errors, you're going to fall below the categoric agreement percentage of 90%, so that would be a consideration. And again, too, this is specified in the M52 on page 52. Satisfactory verification, you're going to update the breakpoints in your system. Some of you may be able to do this on your own, but it's advised that you talk to your applicational specialist for your particular instrument to make sure you're doing this correctly. Now, the manufacturer or the technical application specialist can't come in and do this for you, because they could certainly provide some guidance. You want to ensure the results are accurately transmitted to your patient chart. So just because they're going to be now changed in your susceptibility test system, you have to make sure that they're going to be transmitted correctly into your LIS, your middleware, or your LIS, or into your electronic health record. So you really need to do, as Dr. Van's going to suggest, you need to make sure that the follow-up, that you're actually getting to the appropriate stakeholders, that the correct results are being transmitted all the way to the end point. And you need to inform stakeholders, such as your antibiotic stewardship team, your infection control personnel, and so forth, that this has been done. And they may see some changes in the results that are generated, may see some changes in your cumulative antibiogram, although, it's my impression this is not going to be a significant difference in your percent susceptible, but nonetheless, to understand what changes might occur as a result of updating these breakpoints. Okay, so this is just the worksheet we provided for you, and it's a snapshot of it, and I just included ertapenem as an example. And what you can see here is you can see in the first column the AR bank isolate number, your date and tech of when you'll be testing them on your commercial system, the actual organisms, actual reference results, MIC, and the SIR interpretation. Now, you're only going to be looking at the SIR interpretation, but we included the MIC value because that could help in troubleshooting. And in the column labeled CAAST system, that's where you're going to enter the MIC results. but not interpretation, because then you're going to manually interpret those MICs from the system with the current breakpoints. And I'm showing you what those current breakpoints are for ertapenem, and they're listed right here. And then, too, that's what you're going to be using for the interpretation. Okay. Okay, here's an example, and these are actual data from the AR Bank isolates. And one you will see has a reference result of 4 for, this is for meropenem, this is not ertapenem. The penem MIC for isolate number 1 is 4, and the interpretation is R using the current breakpoints. Number 2 is greater than 8R, and so forth. And you can see that the interpretations for number 1 using the commercial AST system is also R. And number 2, they're both the same, R. For number 10, they're both the same, S. For number 11, the interpretations are both the same, S. But number 8 is R by the reference method, by 4 by your test system. And so this is not in categoric agreement, so this is considered a minor error. But as I mentioned, you are allowed some minor errors here. So at this point, this would not be a significant concern. But again, too, we're only reflecting results from 5 isolates on this slide. To calculate the overall percent errors and the categoric overall percent errors, we have this is actually from isolate. This is from the 31 isolates. Among that set from CDC, 23 were susceptible to meropenem, 1 intermediate to meropenem, and 7 were resistant. So calculating the very major errors, you would use the resistant results as the denominator, so there are no very major errors. There were major errors using the numbers of susceptible isolates as the denominator, and there was 1 minor error, which was in a percentage of 3.2%. So this is not a very high percent, so this looks really good when calculating the percent errors for your meropenem and Enterobacteriaceae. And this is just an example of what you might. Okay, bottom of that worksheet, we also have where you could enter the results of the number of categoric agreement and the percentage and the major, and major errors, whether or not it's acceptable. And you could actually use this to present to your director to sign off on it, and again, assuming that the results obtained are within the acceptable percentages or acceptable criteria defined in the pre-written verification protocol. So that's really important. Also on this worksheet, we have 2 other sheets. One, you could use this for entering the data from any discrepancy resolution, and another for entering results for reproducibility studies if that need to be done. Okay, I forgot to mention here that some of these cells are highlighted in yellow, and we put those on there because these are the values that CDC modified since the original file was generated. So I know if some of you have procured this file from CDC previously, and you may have different values in those cells to those that are now highlighted in yellow. And again, too, these are all difficult organisms to test. And, upon storage, repeated subcultures or whatever, some of these values may change, and it's very difficult to have the, extensive reproducibility of some of these MICs for some of these organisms that, again, are rather difficult organisms to begin with. Okay, what about additional CLSI breakpoints updated since 2010? On the right-hand side of this slide, I'm showing you again the M100 document, the current version, the 28th edition. And in the front of that document, there's actually a listing on the right, again, too, of all CLSI breakpoint additions and revisions in 2010. And I've taken an excerpt of those on the left to show you which of those specifically relate to the Enterobacteriaceae, Pseudoregionosa, and Acinetobacter. In addition to the modifications of the carbapenem breakpoints, also been modifications to the cephalosporins. So I didn't include the carbapenems on here because you already, I think, beat those to a pulp by now. But these are the breakpoints that have been modified or updated since 2010 for the Enterobacteriaceae, a little bit more recent for Pseudomonas and Acinetobacter. So what I want to say here is that if you want to update your breakpoints for some of these other cephalosporins for the Enterobacteriaceae, you could use that carbapenem breakpoint set you are using for the updating the carbapenem breakpoints, but there are also values in that set for the cephalosporins. So you've done the verification for the carbapenems, you probably generated results for other cephalosporins, and this would be prime time to consider updating those breakpoints and if this is something your director wants to do in your facility. If you update the breakpoint, for example, the carbapenem breakpoints for Pseudomonas aeruginosa, you cannot use that Enterobacteriaceae set. You would have to procure another set of isolates from the CDC bank for Pseudomonas aeruginosa, and there's another set for Acinetobacter. This is just a listing of the outdated breakpoints that, to the best of my knowledge, as of about 2 weeks ago, now what status was on the main commercial systems that are out there. So, for example, with the Phoenix, cephalin and cefotaxime, cefotaxime are still not updated. I know they are in the works. Similarly, Microscan, cefazolin, cefepime, and ceftazidime, and meropenem, and also are listed for Pseudomonas rhodopiptazo, because this is another one clinical laboratories may be asking to update. And in order to do this, you would have to get the Pseudomonas aeruginosa organisms from the CDC ARB bank if you wanted to do this. For the Vitec, and I know many of you are doing Vitec, you know that the breakpoints for imipenem and meropenem are still not updated in those systems. We strongly encourage any of you that are using the Vitec to go through the procedure and update your breakpoints for imipenem and meropenem to current breakpoints currently recommended. Okay, just a snapshot of the final resource document that we provided for you. And this is the spreadsheet that we obtained from CDC. That's the CDC AR bank number, the study number, the original study number from this. And actually, these organisms, I don't know if any of you participated or purchased the CAP, that was available, I think, from 2015 to 2017. It's no longer available. But this was the BIT, the Breakpoint Implementation Tool, and that's why these are labeled BIT numbers in this column right here. So those are the same organisms you would have had from that CAP collection if you purchased those, the same organisms. But then I want to point out here, too, that there are MIC and interpretive results for a lot of antimicrobial agents. So, this can have significant value, only if you want to update the cephalosporin breakpoints as well, but also if you have a new system in your laboratory and you want to use these for verifying other drugs, you can use this set of 31 organisms as well for those purposes. This is just showing a snapshot from one of the pages in the AR isolate bank, again, to list all of the sets of resistant organisms or test organisms that are available. And you could order these, but again, too, some of these have large numbers of isolates. You have to make sure. Now, I would not suggest you order these just randomly. Order them if you have a purpose for using them in your laboratory. And again, too, as I mentioned, there are specific sets for Acinetobacter, Baumannii, Pseudoaeruginosa, the gram-negative carbapenemase detection panel. So if you're bringing on the MSIM or even doing a molecular assay for the carbapenemase genes, this would be a very valuable set for you to use for that purpose. And again, you have to order these separately, and there's many more listed right here as well. And okay shipping. Dr. Tam Dan is going to talk about her recent experience in verifying the carbapenem breakpoints for the Enterobacteriaceae, and during that process, they also updated the breakpoints for the cephalosporins. And I think you will find her information very valuable, and you'll probably have a lot of questions for this because she's going to tell you, what they did for this update procedure and some of the obstacles they encountered and the obstacles they overcame. So, Taya, I'd like to turn it over to you, please, and let's proceed.
Everyone, thank you, Janet, and thank you, everyone, for having me here today and for giving us the opportunity to share our experience with this verification study. So at HOR, we did our verification of the revised CLSI breakpoints for the Enterobacteriaceae last year. One of our LS volunteered, or if you ask him, voluntold for this project. It took about 2 months to complete the study, but the actual testing part took about 10 days to complete. And it took us about 2 months because we don't have dedicated staff here for projects such as these facilities, and so the CLS was only able to devote time to the study when staffing allowed. So if you had devoted staffing for special projects or studies like this, you may be able to complete the study a lot faster. Now, and then the other thing is, if your administration is allowed for overtime, and if you have someone willing, you may also be able to complete the verification study relatively quickly. The commercial ASD system that we use here is the VITEC 2. In fact, we have 2 VITEC 2 instruments. So just a reminder, labs are required to verify each instrument, even if they're identical make and model. So keep that in mind when you are designing your study. And the webinar is focused on the carbapenems, but as Janet mentioned, we actually do the verification for the carbapenem and the cephalosporins at the same time. And the data we have on our VITEC card are listed here for your reference if you're interested. One more note, prior to starting the verification, we did check that the MIC range for the antibiotics we were updating were low enough for the revised breakpoints. And you can find this type of information from the package insert of what card you're using. Next slide, please. Can someone advance my slide? Oh, there we go. Okay. So we obtained organisms from the CC and FDA AR bank that Janet spoke about. Ordered the gram-negative carbapenem detection panel in addition to the Enterobacteriaceae carbapenem breakpoint panels that Janet spoke about. It was because we wanted additional isolates for our study, because remember, we had 2 VITEC instruments. So in fact, we tested 50 isolates for the study and spread it between our 2 instruments. And we perform weekly QC according to our IQCP, and you would notice that there's additional QC bugs on here, and that's because those were QC bugs for our Bauer, which we use as the reference method for verifying the cephalosporin urine breakpoint. Next slide, please. The acceptance criteria that we use is the same as what Janet has already described, and it came directly from the M52. So greater than or equal to 90% agreement, no very major error, and 1 major error would be considered a successful verification for us. Next slide, please. And slide is a summary of our results for meropenem. Again, 50 isolates, so the 50 isolates, 30 should have tested susceptible, 5 intermediate, and 15 should test resistant. And as you can see, the results look pretty good with 96% categorical agreement. With the same formulas that Janet discussed to calculate very major, and minor errors. Fortunately for us, we did not see any major or very major errors with meropenem. 2 isolates with disagreement were minor errors. So from this, concluded that verification study is complete, and that we can now use the revised breakpoints for meropenem and Enterobacteriaceae on our VITEC instrument. Next slide, please. We did do some troubleshooting, and here I just have some examples of some of the types of discrepancy we saw. The first thing with all of our discrepant results was to repeat the VITEC run to ensure they really were discrepancy. So for example, the first one is isolate number 44. It's one of the 2 meropenem minor errors that we had. The reference result is an MIC of 2, which should be interpreted as intermediate. However, it tested as resistant on VITEC. We counted this as a minor error for our verification study after the VITEC repeated as resistant. Now the next one is isolate number 7, and this is an example of a slightly more complicated issue, if you will. This isolate was supposed to test resistant against carbapenem, but repeatedly tested as susceptible on VITEC with an MIC of less than or equal to 1. So the MIC values were significantly different, and we've heard that these isolates can be difficult to maintain and may lose their resistance, just as Janet discussed. We tested the isolate against another method in-house, the disk diffusion. And interestingly, the disk diffusion results agree with our VITEC results. So from this, we concluded that this isolate may have lost its resistance and considered the VITEC results as correct. And isolate number 8 at the bottom is another example where we made the same conclusion and said that the VITEC results was fine. Next slide, please. Completing the verification study, we did contact our manufacturer to assist with programming the new breakpoints on our biotech instrument. And I believe something you can do on your own if you have a super user who's comfortable with making changes on your ASD system. But we opted for calling in one of the field specialists to do this. And as Janet mentioned, they may help you or they may say that they can program it because it's, and the reasoning is because they are not allowed to make changes to FDA-approved settings. Our field specialist came in and reset and programmed the new breakpoints for us, and she showed us how to activate it, but we did the actual activation ourselves. Then on the day of implementation, we ran audits to ensure that the new interpretation were transmitting to our LIS properly. For us, the transmission went quite smoothly, and we didn't have to involve our IT or LIS teams. To inform our antimicrobial stewardship, infectious disease, and infection control of the changes that we made, and we didn't get any resistance at all, so they were super supportive of the project and were very happy to know that we were updating our breakpoints. And then very final comment before I hand this back to Janet, I ask the CLS who worked on this project if he has any recommendations for someone who's starting a similar verification study. And all the points he listed were focused around organization, so he said that was really key. So if you had to do troubleshooting, if you have a really good organization, it will help you trace back where problems were and everything like that. So in reviewing the materials that were provided with this, along with this webinar, I think they're excellent and will help tremendously with organizations and documentation for your study. So with that, I think that's it for me. I will hand it back to Janet.
Okay, very much. I think you are a valuable resource for answering some questions that our laboratories might encounter as they embark upon this verification, and hopefully you'll be available to help answer those questions. And also, I might want to mention that if you think about questions subsequent to this webinar, please send them to the email address I think that was provided, by Sam on some of the initial slides, Aaron, and we can certainly direct those to the appropriate persons to help answer your questions, because we're really committed to making sure all laboratories in the state of California are updated with the new breakpoints very soon. So just in summary, I want to say that there is a clinical and public health need to accurately identify CRE, and I think all of you are probably in agreement with that. Failure to utilize the updated breakpoints for Enterobacteriaceae may result in missing, as many or even more than 20% of CRE isolates. The California and Los Angeles County Public Health Departments are available to assist clinical laboratories in updated breakpoints. Now, we're going to come in and subculture isolates for you and test them on your Vitek or your microscan or whatever, but we will certainly try to help you answer questions you may have. And then finally, I'd like to say that please stay tuned to learn more about other public health initiatives to assist clinical laboratories in confronting antimicrobial resistance and susceptibility challenges. We know that this is a very complex area. We know this is not only a clinical concern, but a public health concern as well. We want to do everything we can to help you, because we know this is challenging, and we think that maybe there's ways that we can do this to help you. With that, I'd like to thank you. I'd also like to thank, others at LA County Health Department and California Health Department, particularly Sandy Berla, Eric Ebsen, whom we've heard about, Nikki Green, who's the director of the Public Health Lab in Los Angeles, Sam Sofield, who's very involved at California, Dr. James McKinnell, whom I mentioned was instrumental in, working with laboratories in LA County to get them to update the breakpoints, and his many visits, I'm sure, were very much appreciated. Dr. John Terashita, who's overseeing all of this at Los Angeles County Health Department. But these are just a few of the people, and the teams involved in doing this in both health departments have been, extensive. I'm sorry if I forget any significant names here, but I think we're all very, very grateful to all of them to making this a concerted effort, because this is a very important public health initiative, and I think all of you probably will agree as well. So I just want to mention the subsequent slides will give you more information about ordering the isolates from the CDC and FDA bank. Again, too, if you have any difficulty difficulties with this, please let us know and ask the young person in your laboratory to help you. But again, I think you won't want any difficulties doing this. You have to basically confirm to them that you're a legitimate resource for obtaining these isolates, so then these isolates don't get into inappropriate hands. So I think we're finished with our presentation. I don't know if Sam, Aaron, we want to take any time for questions, but as we mentioned, you could send your questions and we'll compile them all together and send them back to all labs participating on this webinar. So turn it over to.
Thank you so much. That was tremendous, both of you. I think Lynette is going to provide a few instructions about how to answer any questions, maybe just one or two questions at this point if you're still available to address them, Janet and Tam. Lynette, can you provide instructions?
If you ask a question of the panelists or make a comment, please use your chat feature to message me, the host, and I will unmute your line to allow you to speak. You can also type in your questions by using the chat or Q&A panels. You can access these panels by hovering your mouse over the bottom center of the screen, where several icons will appear, and then click on either the chat or Q&A icons to open panels on your screen.
Great. And while we're waiting for everyone to enter their questions, just want a couple things. I think, as Janet mentioned, the webinar recording, slides, tools, we'll distribute them to the webinar participants in the coming day. You can also email us at haiprogram@cdph.ca.gov. Similarly, if you have any questions following today's webinar that you don't have a chance to ask or that we don't get a chance to address, please also feel free to email them to us at this email address, and we will route them accordingly. I'd also just like to follow up with all of you in the coming weeks and and hopefully provide any support you might need as you move forward with updating your breakpoints. And then just a quick plug, we wanted to mention our next webinar where we're going to present the results from the first year of carbapenemase testing performed at the CDPH Microbial Diseases Laboratory. So if there are any questions, Lynette, have you received any?
And through at this point.
This is Sam Horwick-Schofield. I'd like to go ahead with just one question I had when I was listening to Tam's excellent presentation. You mentioned that you all did, I believe, methazolin at the same time as meropenem during updates. And I just wanted to ask, if you thought that was a good approach in terms of kind of a two birds with one stone sort of thing, or if that added sort of considerable time and effort, and for those looking to kind of minimize an effort relates to updating breakpoints, if they should just probably focus on carbapenems. I wonder if you have any thoughts on that.
Yes. So can you guys hear me okay?
Oh,
okay, great. Yeah, so Sam, great question. It did add additional time because we had to do additional testing, especially for the cephalosporin. So now with the other cephalosporins on, if it's on their cards already, they might be able to just, because you run the whole card, right? And so our ceftriaxone, azidine, and cephapine were already on the card with meropenem. So when you run those isolates on the system, the results are already available. So it's the post-analysis that took up that more time if you do it that way. Cephalosporin was a little bit of a different monster because if everybody remember, now urine breakpoints versus parental breakpoints also, and that's why that one was a little bit complicated. But I would say we just wanted to do it really in one shot and just have it done with, and then just let our professionals know that these changes are happening all at the same time, and that's why we opted to do it that way. But yeah, you are right. It will add additional time, especially with the data analysis.
Great, thank you, Tam. And so one question that has come up through the Q&A, I'm not sure if you and Janet are able to see these on WebEx, so I'll just rethink what I understand is the question. It sounds like somebody is working on verifying the Phoenix software with their old microscan, and I guess the challenge is that the BE expert on the Phoenix software doesn't give the interpretation. so they're wanting to clarify, does the user have to set their own interpretation with that? Are you familiar with that system?
Yes, so it's my understanding that Phoenix has updated the breakpoints in their software. And so I don't think any special precautions are needed to address those, but I'm not sure exactly what's happening here. It almost sounds like there's an option for what labs can do. So best to speak with your Phoenix representative, but in the interim, you know, can consolidate these questions. So I see another one here about Phoenix and how that can best be handled, because I'm not sure what exactly is going on here and why this should be such a challenge if they've already gotten FDA approval for the current breakpoints and that's what's on their software. Into that. We will send for, you know, if you think subsequent to this program that you have other questions, please send them in to us, preferably in the next week, and we will compile them into a spreadsheet and send them back to all of you so you can see answers to those as well. And we also will include a few other questions that we did not have time to address during this program that be a benefit to you as well.
Thank you so much, Janet and Pam. That was tremendous, and we really appreciate the follow-up on any remaining questions. So with that.
Yeah, no, this is Sam Horkscott. I just wanted to mention that we will be reaching out to some of the people that participated on this webinar showed interest previously in updating breakpoints and implementing the most current breakpoints. We'll be doing that with facilities that are not located in Los Angeles County. They have their sort of own separate follow-up in LA County. But we will be sending emails and getting in touch and seeing if we can provide any assistance, answer any questions, things like that. So just stay tuned. We've also seen some people ask about can they get a copy of the slides and the presentation, the tools, et cetera? And yes, we're happy to send that out to all participants on the webinar, and we'll be doing that in the coming days. We really just have to make sure that the recording worked and get it online, et cetera. So.
Yeah. Just one more comment. You know, please share you also share any of those resources we provided. The one thing I want to strongly emphasize is that you cannot share organisms that you get from the CDC Air Bank. You know, when you sign those forms, you're signing away and say you will not send them to anybody else. So, you know, that's a very, very important thing. And, you know, there could be ramifications if you share those organisms with other facilities or your friends.
Yeah, that's a very, very good reminder. Well, you know, unless there are any other questions, I know we're about 10 minutes over time anyway, so we really thank everyone for your attention, and of course our presenters. Thank you so much for taking the time. I think we're really going to be able to make an impact and get more labs using the most updated criteria. So thank you again, and of course, if anyone has any questions, they know how to reach us.
Stay in touch.
All right. Have a good day, everyone.
Thank you, presenters, for today's informative presentation. We will email all participants a copy of the tools, today's slides, and a link to the recording in the coming days. This now concludes our webinar. Have a pleasant afternoon. I have to download it. That could take up to 4 hours. Yeah, for sure. We'll find